Gentlemen, thank you for your patience in holding. We now have your speakers in conference. Participation in this conference call is by express written invitation of the AHA only. Unauthorized participants and/or any party that aids and abets such unauthorized participants may be subject to criminal and civil penalties under both state and federal law. Please disconnect from the call or log off the webinar if the AHA did not expressly invite your participation. Please be aware that each of your lines are in a listen-only mode. Please note that you may ask a question at any time by submitting your questions through the chat pod located to the right-hand side of the slide. It is now my pleasure to introduce today's first presenter, Elisa Ars-Pacachaga. Ma'am, you may begin.
Thanks so much, Brandon, and good morning or good afternoon to those on the East Coast, and welcome to today's webinar titled The Business Case for Humanity in Healthcare. I am really pleased to have the team from the Institute for Healthcare Excellence, who we've partnered with over the last several years, and is really focused on enhancing human connection, experience of emotion at work, and the culture of excellence. And also, I count as really just wonderful colleagues here to share the work that they have done over the last couple of years, and the team from Parkview to share their experience in really addressing burnout, thriving, and driving healthcare value. So let me briefly introduce our presenters today. As mentioned, if you as the presentation goes through, if you have questions, please type them into the chat box, and we'll do a panel session at the end with our presenters. So I'd like to introduce you to Dr. Bill Maples, who's President and CEO of the Institute for Healthcare Excellence, Dr. Mitch Stucky, President of Parkview Physicians Group, Dr. David Clark, Section Chief of Gastroenterology at Parkview Physicians Group, and Jillienne Kenner, who's the Regional Manager for Gastroenterology at Parkview Physicians Group. I'm really excited to hear about their activities and their presentation and look forward to sharing this with you all. So Dr. Maples, with that, I'll turn it over to you.
I'm delighted to actually share the story of Parkview Health as we really worked on the whole problem of burnout, thriving in the context of creating value within their gastroenterology department. Before we get started with the story and the background, I just wanted to recognize the American Hospital Association, both Sarah and the Institute, for really being our strategic partners as we really worked on this complex problem of burnout as well as solutions for that over the past few years. The National Taskforce was made up of healthcare executives, physicians, nurses, frontline caregivers from a multitude of institutions as shown on this slide, and we're grateful for all of their input over the last several years, which had significant impact on the approach that we use for burnout, thriving, and the approach we use at Parkview. One last note of recognition, the executive sponsors for the National Task Force included Dr. Bridget Duffy, Dr. Paulus, and myself, and without their help and guidance, this would have been a more difficult journey, so we're grateful for their ongoing support over the last several years. As we think about what we'd like to have you walk away from the webinar today, we'd like 4 objectives. First of all, understand how this burnout problem contributes to challenges facing every healthcare organization, and particularly today in the COVID-19 pandemic, the complexity of that has become even greater. We'll give a brief review of the National Task Force work and how we've redefined the conversation from burnout, which actually, if you keep talking about that, just results in more burnout and less solutions, as we've seen over the years. And from the work of the task force, the meaningful solutions necessary to reach caregivers thriving as well as resiliency. We'll hear from the Parkview team, and particularly their gastroenterology division under the direction of Dr. Clark, how they really approach this challenge within their organization, and as well as discuss the impact and the outcomes to date that they have experienced from participating in the work. As we get started, just time to quietly reflect for everybody that's joining us today on two questions. The first is, what allows you to go home at the end of the day with a good, tired feeling? We're all going to go home tired. The work seems never ending. But those days that you go home with a good, tired feeling, how does that happen? And a related question, what is your greatest source of job satisfaction or joy in your work? I'll let you just think about those two for a few seconds before we move forward. The work of the task force has really resulted in a common list of barriers to achieving peak performance for individuals and teams within healthcare organizations. And the common list are outlined here: competing contradictory priorities, legislation, shifting teams, technology, although often introduced to help, can sometimes hinder, processes, we hear about that all the time, that our processes are not really optimal to really allow us to do our work. There's external factors in terms of shifts of reimbursement. There's leadership issues, and oftentimes we hear, how do we get our team engaged as these barriers? So our work actually centered around these barriers, because our ultimate goal is to have everybody, individual and team, reach their peak performance. When we think about drivers of burnout, drivers of improvement, there are three pillars that need to be addressed. One is the processes in which we do work. We cannot really dismiss that bucket of work. It's really, really important, but in and of itself is not sufficient. We do need to look at technology advances to really help improve and move our performance in the right direction. And then the third pillar is the culture, the environment in which we do the work. And oftentimes we talk about that, but the solutions and interventions that we introduce don't often move that culture to a place that optimizes our performance. When we think about burnout, I think this is probably familiar to most caregivers. It's pretty prevalent. About 30 to 40% of physicians and similarly nurses are experiencing some aspect of emotional exhaustion or burnout. Here it is, 34% of nurses are burned out. So 1 in 3 or greater of your team is actually experiencing some burnout and the consequences of that. When we think about the extreme of burnout, we have an estimated 300 to 400 physicians will take their lives every year, and that's actually more than double the general population. Certainly, we would like to have solutions and intervene before anybody needs to really get to this end of the spectrum. Tremendous loss for the individual, families, organizations, society, etc. So how may burnout show up? A lot of times people don't come and say, I'm burnt out. Sometimes they do, but sometimes they'll say, I'm not certain I can keep this going. Maybe I should go part-time. Should I find a new job, etc. I just made an error. I have to quit that committee. There's no way we can increase encounters. I don't care about more revenue when I'm drowning. Another new leader, this only is going to get worse, ... You can see it shows up in many, many different ways within our organizations, just sort of clues to be watching out for yourself and for your colleagues. It also shows up as disruptive behavior, sometimes extreme disruptive behavior, other times a more mild or passive-aggressive form. But when we look at disruptive behavior and burnout, the more burnt out an individual is, the more likely they'll demonstrate disruptive behavior. And disruptive behavior actually has significant consequences on the teamwork climate. We're always talking about high reliability. And on the safety climate, on the work-life balance climate, the personal burnout actually goes up, and depression symptoms also goes up. So you can see they're intimately connected and have some consequences that none of us would like to actually encounter. It's also really expensive, and this is well now reported in the literature, multiple sources, that the cost of physician burnout is about $4.6 billion a year. I often I'm a bit puzzled when I think about the cost of this problem in medicine and healthcare organizations and leaders talking about the problem, but yet actions sometimes don't follow the magnitude. This is probably more costly than technology advances, et cetera, and sometimes we're not acting as if this is this significant amount of financial burden. Stanford University looked at the cost of burnout and looked at turnover of doctors with or without burnout symptoms within a single department, and the estimated cost for this particular department was up to $50 million or so a year on burnout. And looking at the cost of nurse turnover due to burnout, it's about $9 billion a year. So not trivial when we put it in perspective. There are other consequences, and studies have demonstrated that primary care providers who are burnt out will actually sometimes make maybe not the best decisions and send patients to the hospital when the admissions are preventable. Another whole economic cost, but also a personal cost to the patients and families, as well as colleagues within the hospital system. So decision-making is affected as well. The literature is not soft on this anymore. Patient satisfaction is absolutely affected in a negative way. Medication errors are driven up, infections are driven up, and actually do patients live or die, the mortality ratios are actually driven up in the context of clinicians providing care when they are burned out. So a lot at risk here if we don't get this right. And this is a nice study that looked at what have we done to actually reduce burnout. And unfortunately, our interventions to date have demonstrated small reductions in burnout, which may be one of the reasons why healthcare organizations and leaders haven't really acted, because the question always comes up is what do we really do, and how can we have a meaningful, sustainable impact? When this meta-analysis was done, they identified that more effective models and interventions actually had to focus on not only the individual, it's not just the individual's challenge, it's the team and the organizational challenge and relationships that were incredibly important. So Task Force and all of those organizations that met and contributed their experiences, their wisdom about what caused burnout as well as solutions for burnout. You can see some common themes here highlighted in the bolded print, that many of them had to do with the interpersonal relationships that were important, the desire for caring, empathy, all of this concept of team and relationships was critically important for organizations to really try to prevent the burnout. There was themes that came up about how leaders were leading. Were they leading in a human-centered way, an environment that actually helped their team members reach peak performance? There were multiple themes of trust being lost between physicians, administrators, nurses, and physicians, all of the team members. There was themes of lack of appreciation for all of the work that individuals and teams were contributing, did not feel that they were being valued, and the need to create a safe place, this concept of respect and engaging patients and care with the patient at the center of the team. The solutions were really meant to focus on a couple things. The importance of bringing leadership and the personnel together within the organization to build trust, skills that actually drove teamwork, skills that actually built strong relationships and collaboration, and then this whole thing of reaching thriving and resiliency, throughout one's career. So those themes are actually all captured and built into the solutions program that I'm about to share with you. From that, we realized our approach had to help leaders lead differently, help team members create the positive culture of teamwork and connection, and then the work on processes and design, and how could we actually do that and hardwire these changes within the organization. So all of us have probably experienced programs where we've learned some interesting, stimulating things, but the question is, what do you do when you go back to the workplace the next day and integrate those into the daily workflow? So those were the challenges of creating the blueprint after we had the wisdom collected from all of the healthcare institutions. And again, when we designed this, we wanted to pay attention to all three pillars: the culture, the technology, and the processes that were actually occurring within a department area that we were working with. And then I wanted to just highlight the journey here from, on the left-hand side, from being burnt out to the redefining that to a place of what does it take to be in the situation where you're actually thriving, individuals and teams are thriving, because that's really what we want to measure, and we want to have solutions that will help us get to the thriving, not just prevent burnout. Zero burnout is not the stopping point. It's actually getting to that point of thriving. And from neurosciences and behavioral sciences, the two definitions on the left were somewhat stimulating and eye-opening. When we think of burnout at its core, it's the impaired ability to experience positive emotion. And if you've ever had burnt out moments, think about that yourself. Think about colleagues that may be burnt out, that they pretty much stay in that negative space and nothing really surrounding them. They can't recognize any positive things that are happening around them. And when we get to the culture of thriving, it is just the opposite. Outstanding culture at its core is the ability to cultivate positive emotions on a frequent basis in small doses, not the grand celebrations of employee of the year, but how do we do this frequently in small doses? The positive emotions that I'm talking about are in the center of the slide here, and anybody that works in healthcare has an encounter with each of these multiple times during the day. For a moment, think about your day and think about how often you perhaps were in touch with these different emotions as you think about your encounters that you had. If we can tap into these, joy, hope, gratitude, love, serenity, we actually have two effects. One is what we call a tiny engine effect, which keeps us going, keeps us engaged. That whole thing of engagement comes up again, keeps us wanting to move forward. We're being valued for what we do and what we offer. Several of the things that came up in those themes from the National Taskforce. It also has, when we tap into these emotions, it has an undoing effect. So anything that may have been difficult, a negative encounter, things that may have really been challenging, when we tap into these, it actually undoes the negative consequences of those experiences. So it's a win-win situation. The challenge is as we do this work on moving from burnout to thriving, how can we actually keep this in mind to tap into these positive emotions frequently in small doses? And one additional thing, we have to remember that burnout is a contagious disease. 26% of your burnout score, your individual burnout score, is predicted by the people that work around you. Likewise, thriving is equally contagious. So when we can make that move from we're burnt out to we're thriving, it will be a contagious effect, and it is the organizational template for excellence when your teams can access these positive emotions. So with that, the National Taskforce developed a 5-step process to really help departments, organizations move from emotional exhaustion or burnout to thriving. First of all, we, with working with some national thought leaders, Dr. Sexton, Marcus Buckingham, we actually came up with a measurement of thriving and resiliency rather than just measuring how much are we in the hole with emotional exhaustion. It changes the conversation around what we do, and we were also able to map solutions to really achieve thriving based on those measurements. That's the first time that actually has been able to be done in this whole burnout journey. Secondly, we have some specific work helping leaders of the organization lead in what we call a human-centered way. How do they create and foster the environment that promotes trust, teamwork, respect, compassion, etc.? Because how they lead has a profound impact on how the team responds. The third step is to invest in some skills for frontline caregivers to really develop a high reliable team, a team that is rooted in trust and respect and performance. The next step was to look at key processes that were occurring within the area that we were working, in this case, the gastroenterology department, and look at ways that we can amplify joy. That actually helps us connect to positive emotions and minimize hassles, which actually takes away from those positive emotions. And then the last step is a human-centered design session where we take everything that we've learned from each of the steps and consciously look at how we can hardwire the way that we do our work so that we can build each of those skills into every step of the day going forward, all with the aim of connecting to positive emotions frequently in small doses. And then we obviously remeasure. So with that framework in terms of how we conducted this work, I'd like to turn this over to Dr. Stucky and have him lead off the Parkview team in terms of their journey that I'm excited to hear. Mitch. Mitch, I think you might be muted.
Okay, how's that?
Good.
Okay, now I'm not. All right, thanks, Bill. I just want to say a few words about how Parkview Physicians Group got involved in IHE to begin with. And we started out, we were really looking at how we could improve the patient experience. And so Bill and I started working together several years ago around the relations course that they also have. And if any of you have done this course, a lot of the work is done by actual providers, physicians, and APPs that are within your group. And so we had a volunteer group of 20 or so facilitators that started doing this work, and they end up training the different providers. And so we voluntarily asked the different providers to take this relations course. As we started to do that, we found out a couple things. First, that as we measured the experience that our providers were having, we started to see a significant improvement in the engagement of our providers. I'll show you a couple slides. This slide, and then probably the most impressive slide was the next slide, where our burnout numbers went down dramatically, more than we have seen in any of our other efforts to try to help the providers and get them into a better place and have a good day, even though it's a hard day, as Bill says. So by seeing these numbers, we started more and more realizing that the work that we were doing really wasn't about just the patient experience. It had that positive effect, but it was really about the well-being of our providers. The things that came out of that then were a couple things. Number one, the feedback that we were getting from the providers that were taking the course is they wanted their own people to, their work people, their coworkers should be taking this course too. And so about 6 or 8 months into this, we actually developed the same process with our coworkers and started rolling this out to all of our coworkers. Before COVID, we've gotten through about 80% of our coworkers and providers. The second thing that came out of it was really coming from the facilitators, and the facilitators started asking, okay, we're getting towards the end of this, where do we go now? What's the next thing that we do to keep this going, to really, once we have all the providers trained in relations, what can we do next? And so Bill and I talked, and really the next step centered around working with a particular team, as he pointed out in his previous slides, identifying a group of people, a team, a specialty, things like that, where we could really focus some of all the other pieces of the work that Bill does. So this is just a slide that gives some of the feedback that we received through our providers by doing the relations course. So as we thought about working with a specific team in Parkview Health and Parkview Physicians Group, Dave Clark, who is the leader for the GI service line, was really doing a lot of work in trying to build up his team, establish a lot of the workflows to make them more efficient, just doing a lot of the work that we thought could really be helped by the kind of work that Bill and his team did. So I'm going to hand that over now to Dave, and he's going to give you a little more detail of where he's at after he volunteered to take part in this.
Thank you, Mitch. To put things in context a little bit, in 2018, when we were getting started down this pathway, things were fairly dire. We had 3.6 FTE gastroenterologists, and we had in the new patient queue close to 10,000 patients waiting, and have already acquired, actively being managed. We had far greater number of patients than we mathematically had spots to provide care for them. And obviously, that was very stressful for the whole team. Appreciation that Dr. Maples mentioned was essentially almost a negative number, and that we were underserving essentially all the patients and the rest of the health system, as well as each other. So we were recruiting at that time unsuccessfully, and we made a decision to create what we believed was the ideal state practice for the future, and to completely abandon the historic model and change the care model. And we did a series of things to do that, even with small numbers, to start to separate inpatient from outpatient care and build specialty care, and start to work on the notion of standard work. But we were so volume overwhelmed and personnel short that we weren't going to be able to functionally achieve that until folks arrived. And so we aggressively marketed, recruited to that new model very successfully, And in 2018 going into 2019, we acquired 10 gastroenterologists, 13 APPs, and ancillary nursing staff, et cetera, that goes with that group into an inadequate space and creating additional subspecialty care and moving to new work sites that were variably staffed, mechanically different from one another. And so we knew all that was coming at us as we had agreements from all those folks to join the practice. And then the question was, how are we going to have that level of complexity across that number of sites with essentially no culture and no relationships? And so one of our strategies was to create a user manual, of which about 80% of that was culture. Just what do we believe in? What are our guiding principles? What underlies our decision making, and how do we interface with each other? The main focus of that was the shift to team-based work as opposed to individual provider-based processing. And so we started down the path of writing a true user's manual, a book, if you would. And the first pass of that was in a very minimalist outline form. And I was surprised at how much that minimalist form engaged people into the conversations about deeper understanding. And that as we tried to flesh out the user manual just with Jillienne and myself, there was less engagement to that. And so it was clear that even then that we were going to have to hold off to some degree until all of the human resources were present to really do that work. And so we were already laying some foundational groundwork as to how that might occur. But I think those first early meetings of the engagement, which demonstrated respect and curiosity as to other people's viewpoints, really sort of set the stage for future success. And when I was talking to Mitch about that, and he was referencing the potential of adding us to the task force, the alignment just seemed so very strong that I asked if we could participate in that. And that's how we came to be involved. And I just wanted to give that background because at the moment when we were starting, you know, burnout was tremendously high. The stressors were tremendously high, and we knew we had a lot of work to do along those lines. So that's sort of the background as to what we were doing, why we were doing it, and where we were. And I can turn over to Jillienne then to start talking about our engagement and processing as we move through that with the task force.
Okay, so looking at the slide in front of you now, this is a repeat of what Dr. Maples had already talked about, giving you the overview from how the National Task Force structured the program. And what I'm going to do is talk you through the actual steps and how it pertained to Parkview and what we did within each of those steps so that as you go away from this webinar today, you actually have some specific examples to put to this program. So in step one, that's really the measurement, the pre-measurement step, so that the National Task Force and specifically the operational arm of that, the IHE folks, have a baseline from which we can work very specifically on your team. And I do want to say here, I think that this was really important because though the program is structured such that each step is consistent for every organization with whom they work, it is very tailored to the individual team that they're working with at that time. So what this looks like is the folks from IHE actually come on site and conduct as many one-on-one conversations as possible with team members. So you can see here that they actually conducted 45 one-on-one interviews, which gave all different folks from our team the opportunity to provide input in a very comfortable and very safe manner so that they could just truly be open and transparent. We did kick that off with an electronic survey that was anonymous to start with. We also did a lot of work communicating with our team, having laid the groundwork between Dr. Clark and myself, that one of our foundational beliefs is to be as transparent as possible, even if it's not always comfortable or not always what they want to hear. And therefore, when we started down this path with the National Task Force, we used that foundation to say, this is an example of us truly meaning that, and therefore we really want you to be as open and honest as you are comfortable with in giving your feedback to the IHE team. Some key learnings that we found from this first step were that folks on the team really wanted to continue to build those relational aspects that were actually visible, that something that they felt could be tangible among the team. Everyone had heard us lay the foundation for a long time and really wanted to see some of that come to fruition. We heard a lot that they knew that we were trying to do things, and the whole team was really at this point where it felt like a tipping point where they really wanted to see something come from that at this point. They really wanted to also focus on, within the workflows, things that were, again, going to really be tangible for them, that would improve their day by decreasing a lot of the hassles that they had. So some of the pre-pilot data that we received, as you can see here, these are, in my opinion, from a leader standpoint, these were pretty low percentages, I felt like, on things that were, again, from a leader standpoint, something that I feel pretty strongly about, that I'd want to see my team being able to respond much better on. So feeling supported during times of high stress, which we can all appreciate is every day in our world. Also feeling closely connected to the mission and the purpose of the organization. Also, this is where Dr. Clark and I really would like people to be able to respond a lot more positively to that question as it relates to our department as well. Treating each other with respect, making sure that folks really can appreciate that people care about them. Teammates having each other's back, having that attitude of teamwork where they felt like they were in things together. So those are some of the questions that we had that really stood out to us in that the pre-project data. With that then, some of those specific questions were correlated to thriving, not just for Parkview, but again, this is where we tap into the large database of information collected by Duke University, and some of the questions here that you see, having a chance to use their strengths every day at work, just outright asking if they feel like they're thriving, being able to make a meaningful difference in their work, and often having something that they look forward to every day. Those were indicators of thriving scores within our department. And you can see where Parkview stands relative to the rest of the folks in the Duke Medicine database. So we definitely had room for improvement there. Also then, when you look at recovery scores, it's not just enough that folks feel like they're thriving in the moment, right? We understand that when they've had a stressful day, when we've had a pretty significant event in the workplace, folks need to be able to go home and recover from that so that they can come back the next day and also be thriving. Some of the questions then that were asked in the survey were being able to bounce back quickly after difficulties, being able to regain that positive outlook, being able to adapt to events in life that they're not able to influence, and then their mood, being able to reliably recover after frustrations and setbacks. Again, you can see where Parkview lined up to the rest of the folks in the database. Once again, we saw that we had quite a bit of room for improvement there. And then how thriving and recovery relate to burnout is really the root here of what we're trying to get to. So as Dr. Maples mentioned, it's not enough that you just identify that folks are burned out. We need to put all of these things together, right, to make sure that we're really addressing the root so that we can improve burnout. And as Dr. Stucky mentioned, Parkview, and specifically Parkview Physicians Group, has invested in quite a few things in the past, but really tying these three concepts together. You can see, again, with our group, we had significant opportunity. It makes sense when you look at the lower scores on thriving and the ability to recover to see that, yes, we also have a problem with burnout. And so some of the questions that related to that were events from work setting affecting their life emotionally in an unhealthy way. From a leader standpoint, if you just pause and reflect on that, that's a pretty significant question. Also then feeling burned out from their work, obviously just an outright answer to that. Feeling fatigued when they get up in the morning and have to face another day on the job. Feeling frustrated by their job, and then feeling that they're working too hard on their job. So after we have the opportunity to gather the information from the survey and the in-person interviews, then we look at the feedback from both a thriving and a recovery standpoint. But again, you don't take those independently of one another. So what this image shows you here is where the key points from how respondents answered for thriving and recovery overlap with one another. And these are all of the positive emotions that Dr. Maples addressed earlier in the presentation. What we're really looking for is, if we're going to invest in this particular team, where are the areas that we should start and really get the most impact from our work here with the National Task Force in order to really address thriving? We want to see that increase. We want to see recovery increase, and therefore we would see burnout decrease. For this particular team then, what you see is that gratitude and appreciation were the areas that we really needed to focus on in order to have the largest impact or most significant impact on thriving and recovery. After we gathered all of that data and got our feedback together, then it was time for us to move into the human-centered leadership. And again, as Dr. Maples mentioned, part of the National Task Force goal was to make sure that leaders were leading in a way that set the stage or set the foundation for all of this work to happen. And there have been a lot of roads that we've traveled down in the past. This human-centered leadership, though, was really focused on specific skills, and you'll see on the slide in front of you that all of the bullet points represent a specific skill that was not only trained during this step, but was also practiced during this step. And the ones that are bolded, the powerful questions, the feeding forward by saying yes, that, yes, or yes, that, I'm sorry, and appreciation, those are the three areas that were really, again, most impactful for this particular team. Again, those are three of the key skills then that as we move forward, we really wanted to make sure that we were practicing routinely throughout the rest of this program. So some key learnings that we took away from the leader training was that we really needed to have reflection time and really encourage leaders to continue to reflect, because that's obviously most important when you're learning new skills and really evaluating whether you're implementing those new skills. The team was able to appreciate value in the relationships and understandings of not just the other leaders, but everyone else within the team as human beings. Seeing the connection between the skills and building vulnerability and trust. That was pretty significant in this stage, and that's why it's so important that you get together as a team to do this, so that you can really be vulnerable with each other, and that's when you get away from all of the noise of the rest of the things that happen in our world and really be able to connect with one another on a human basis. So moving in then to step 3, this is where we get the rest of the team involved in a program that is also titled Relations, similar to the IHE program that we implemented for all of PPG, Parkview Physicians Group. However, this was really specific to the team. So what this looks like is getting your entire team together, from all of your providers to your nurses to your non-clinical staff, and in a 4-hour course, combining team members so that you can have, again, those really vulnerable questions, those vulnerable discussions, so that folks start to strip away maybe the way that they're used to behaving in the work environment, and have another type of relations course that really allows the team to start to think of one another as a human in the team setting, strips away everyone's titles, and really gets to the root of each of us as humans and why we're here. Again, some of the skills that were not just introduced but practiced are on this next slide here. And the ones that are bolded, again, were the ones that we knew as a leadership team moving forward we really wanted to encourage for folks to continue to practice, and the skills that we really wanted to continue to focus on taking to the next level as we left this step. So some of the key learnings here that, again, I mentioned, it's just imperative that you have every member of your team and a mixture of those members. So it was a pretty heavy lift for us, a pretty heavy commitment. We essentially stopped operations for 2 days so that we could get everyone to a 4-hour session. It's the opportunity then for a physician to hear from the registration desk to be able to understand how all of the patient impacts or patient situations in the day impact them from their perspective, and vice versa. So it's an opportunity for the group to dialogue, to get into that vulnerable situation so that they have a safe space to talk about things openly. And then some of the participants in this phase were still focused on, I just want to put my idea out there and have a single fix to something. And we identified during this key learning that that was something that we would have to continue to communicate as we participated in the following steps. So step 4 then is the experience and process mapping. In this stage, this is where we really took time to document the workflows after we observed them real time. We identified opportunities here for folks to actually provide feedback on where they saw hassles in their day, where they experienced hassles. We asked them for feedback on really where we could create stronger human connections. And then we, as a team, sat together and documented these processes. Some of the initial data that we pulled was just to help us in this process. So we didn't use any of this data to create a solution. Obviously, the volume would be something that would be important for these type of workflows that we are focused on, patient satisfaction, coworker engagement. And then here is where we mapped out what the workflow actually looks like. And as an operations leader, I have participated in so many different types of process improvement events in my career. And what I really appreciate from the task force work is what you see on the slide in front of you. Everything that is denoted by a heart is actually identified by the team as we're mapping the process as an opportunity for a human-to-human connection. So every other time that I've done process improvement, it looks similar to this. It could have tact time associated with it. You could be looking at ways to improve whether it's your turnaround time or whether it's your just-in-time supply, whatever your goal might be, it looks the same without identifying really where we have those opportunities for human connection here. And it's not just about the human connection, but it's about building in that we will always have an event there to continue to foster that human connection. So then the team also worked on what looks very busy here on your slide, but really prioritizing from, if you look at the axes here, the effort of a particular project and the impact of a particular project. And because we had worked early on, looking at so many of the processes that needed improved when we were so short-staffed with both providers and frontline staff, as you can see, there's not any project that's left down in the low effort, low impact section, because we had already at this point knocked out all of those what you typically call low-hanging fruit. So as we started placing each of our topics on this grid, you can see most things really took place in that upper region where you have high effort and high impact. As a team then, we chose out of all of these topics which ones would be most important for us to focus on. Again, going back to the early data that's compiled right from the beginning on what's important to our team. So some of the SMART objectives that we came away from this step with, is that we really needed to focus on these projects, which were handoffs between the inpatient and outpatient team, handling questions from patients who walk in at the front desk and are not scheduled, the whole checkout process from a clinic visit, and then continuous validation of positive and culture-enhancing behaviors among all members of the team. In step 5 then, this was the step where we really start to put some structure to those projects that we decided that we really wanted to focus on. So as you can see here, we're really looking at several steps to drive this process. And we wanted to make sure that we were developing a process that really hardwired the skills and that was centered around the actual folks who do the work every day. And one of the ways that we did that was with an empathy map. So you can see, using just one project example, this was our inpatient to outpatient handoff. So a patient has been in the hospital and now they're going to be taken care of by someone who's never seen them before because they're going to be followed up in the outpatient environment. And this empathy map is an example of feedback that we receive by asking folks who actually do the work, when you do this work, what do you think about this work? How does it make you feel? What would you say when you're doing this work, and what would you actually do? And so here, I want to give Dr. Clark an opportunity to provide some feedback on what this felt like creating the empathy map during this phase of the project.
Dr. Clark, make sure you're not on mute, sir.
Thank you. I can't emphasize enough that the human connection aspects of these things are critical. And as we were moving through that, the awareness of the participants of that changed throughout the event. And I think the notion that there's a difference between bland operations and that operations actually end up representing relationships and relationship building was a fundamental change.
Thank you, Dr. Clark. We also identified during this that it was different. I believe I failed to mention up until now, I apologize, that this was a subset of our group because we have over 100 people on our team. And this level of detail really maxes out at about 20 to 25 people to really functionally participate. But what this step of the project allowed us to do is take what we were doing in a team-based yet conference room and bring that back to the rest of the team to really get their input and their buy-in. And I think this may have been the most impactful step. As I mentioned early on, folks were looking for something real to come out of this. And when we came back up with our initial brainstorming ideas and the 4 projects we had identified that we really needed to focus on, and then also asked them for specific input, we could really see the impact to the rest of the team. So moving forward from there, after we built the empathy map based on feedback, this is where we were able to have a little bit of childish fun in the project. Obviously, stick figures must be our artistic forte because that's what you see in front of you. So we really looked at how we could visualize these processes playing out. And we incorporated what we had heard from the team members, and then also, again, identified where do we have human-human connection. That's why this step of actually creating a prototype with people walking all the way through the process is so important, because it allows you to visualize as a team where we could interact with each other and where we should create those always events. After we prototyped on paper, then we all broke off into our specific teams and took that prototype, one step further and created a video. And this is where it's a useful tool that is actually tangible from this work, because the prototype videos are a demonstration of the process start to finish with all of the elements of relations built in and the always events, so that with the rest of the team, we're able to have something visually we can show each of them, and that we could always come back to if we feel like we're drifting away from the intended workflow, so that we could sit down as a team and watch that, and as we have further team members join, we have something that they could watch so that they actually see how to cultivate positive emotions inside of their daily work. And then the learnings that we took from step 5 are that it really takes that intensive coaching, going all the way back to the leader training. It reinforces all the way through the program that these are not just the skills that you learn one time, but that it requires leaders to continue coaching so that these become actual hardwired skills, so it becomes something that we do, not something that we just talked about at one point. And also in step 5, it was really important that we acknowledge that while the engagement was strong throughout every step, only in the experience and the design sessions did purpose, approach, and skills really click for most of the participants. So it's a process that these folks were going through. And then in the design process, we clarified that what use of skills could look like in an ideal setting, again, especially in those prototypes. And then we also really identified that it was going to require ongoing work, not just to implement the elements of the task force program, but then to continue to build upon that as we grew as a team. And here are some of the quotes from our participants. These would be participants at any stage through the program. And you can see here that folks really understood that this would be a domino effect that would inspire progressive positive change. Another comment was that this journey really improved the team dynamics and the interpersonal relationships. They could really identify that it translated into improved patient evaluation and perception of care, and really felt like they now had a toolbox of skills that they could carry forward, supporting less burnout and increasing employee retention. The next is that this impact of work can position Parkview as a pioneer in the delivery of medical care. Projects like this could have a substantial impact on quality of care and safety. And before this work began, I was seriously considering transferring to another department. The burnout factor had turned into a dark cloud of negativity that I wanted no part of. this has created a positive shift that has inspired me to stay. So pretty meaningful feedback that we received from our team. And with the feedback, we will also continue to measure moving forward some of the holistic outcomes that we would expect. So we will continue measuring the burnout, the emotional recovery, and the emotional thriving, which translates also directly to the team climate, the staff and provider engagement. Turnover is obviously a representation, of all of those things. And then also observed use of leadership and team skills, patient experience, operational efficiencies, and harm and patient safety. So this is now a pretty meaningful slide that we have that's actual data from the pre and the post survey. And you can see through this entire process that we were able to appreciate what I feel like is pretty significant improvement on our burnout score. So pre, we had been pretty high in relation to the rest of the folks in the database, and Parkview post is really has moved a good distance toward what we want to see, which is a lower representation of burnout. And again, some of those questions would be events from work setting affect my life in an emotionally unhealthy way, feeling burned out from their work, feeling fatigued, feeling frustrated by their job, and feeling like they're working too hard on their job. And so what this means for Parkview moving forward, Dr. Clark again would like to speak to how this really impacted our team after going through the entire process.
Thanks, Jillienne. So one of the things that we really emphasized as we were recruiting people and as we were having post-recruitment early employment meetings with individuals was the concept that we do not do slogans, that we will always be translating our written beliefs and principles into working operations. And that means our committee structures, what kind of committees we have, who's on those committees, so that everyone has a voice and engagement. And as we were going through those various steps, it was striking to see how people would have what I would call an aha moment at various times throughout the course in which they really started to understand it and immediately bought in. And it changed the way that they started thinking about situations, and that you could literally see discussions, attitudes change as we move through that process. And I think it's important to note that the variability of that, how early on or how late into the process that occurred, and at what point during sessions did that occur. And along those lines, there was one of the exercises in which we went to the office work zone and interviewed people, sat down and got their opinions. And that act of respect of going to someone to ask for their input, to take notes, and to describe why it was you wanted their input and how that was going to translate into workflow changes for them, you could see those people having aha moments. As Jillienne referenced, that was sort of the literal representation of creating our beliefs into actions. I think the other thing that was striking as we were going through those is that each team member started to gain an understanding of the complexity of processes, whereas people viewed things as a simple problem and were frustrated that a simple thing wasn't fixed. When they mapped it out and realized how many people that touched and how many workflows that altered, there became a respect and understanding of that. And then I think a big thing that I would really like to emphasize, the creation of time and space to have the team engaged was viewed as a very meaningful act of respect for the health system for them. And that was highly motivating as well. And the last is that what Dr. Maples referenced about frequent and small doses. Can't emphasize that enough, in that it has to become part of life, and that modeling in the workplace can be negative or positive, and it doesn't take much on the positive side to contribute to a meaningfully positive change overall. So it's been a profound experience for us. It's helped facilitate many of the changes that we were looking to make before we started, and it is so clear within the group who has been through and who has not, as to how they go about approaching problems, how they verbalize them, the context of inclusiveness and curiosity versus judgment. It's profoundly impactful. Mitch, I didn't know if you had further comments.
Dr. Stucky, just please make sure your phone's not on mute.
Yeah. No, I don't have any other comments. I think, Dave, you said it very eloquently.
Be happy to answer any questions if there are any.
All right. Great. Thank you so much. This is Alyssa again. Just wanted to start us off with a couple of questions. And again, if you have questions for our presenters, please type them in the chat box and I'll be helping to moderate. But I'm actually going to start off with a couple I've been writing down during your presentation. And Dr. Clark, let me start with you. How did you really, in the midst of all this volume overload, really have the ability, and what were some of the conversations you had to really get the entire team and the leadership on board in the midst of, everything's coming at you? How do you take that deliberate stop and pause to say this is more important right now?
Well, you need a Mitch Stucky, one. You need support from the system to allow the time and space to do that. But it takes a tremendous amount of leadership time for, Jillienne and myself to do the meaningful conversations, to recognize and respect the problems, to not sugarcoat anything. Jillienne and I both believe in hyper-transparency, so we never try to minimize something. It's just focusing on a positive, different future and how do we make progress. And we had a conceptual outline of how we wanted to move forward. This work offered a meaningfully helpful structure to that. But there's no escaping the time and effort on a one-on-one basis of lots of conversations to motivate people.
Absolutely. And Jillienne, I think this one probably makes most sense for you to start. Can you give us some concrete examples of the hardwired human interaction changes, how those little hearts on your workflow actually exist?
Sure. Yeah, so one very specific example that folks in an office setting may be able to relate to is when patients walk in without having an appointment. And everyone on the team seemed to be pretty burdened by that because the folks at the front desk were trying to serve the patient as best as possible. However, that required them to go back to the staff in the back who were actively taking care of either scheduled patients or patients on the phone. And that created a really tense environment sometimes because everyone felt like they were being put in a really hard situation. And unfortunately, the feedback we received immediately from staff was that they felt like they were taking out that frustration on each other. So what one of those true always events looks like that would be hardwired in is when you are physically handing a paper, for example, to a nurse from a patient who's walked in at the front desk, and that patient has maybe said, I don't feel comfortable calling, or I was already on campus, or what have you, so I just really have a question that I need to ask the doctor. That, of course, goes to a nurse because doc would be scheduled with someone at that time. Nurse is busy with something. As that front desk person is bringing that paper back to the nurse, interrupting her workflow, then having something that is a specific statement from the front desk person to say, I appreciate that you're busy right now, or I understand that you're busy right now. I have a patient who needs something. Can I ask you this question now? Would you prefer I go to someone else? Giving them the opportunity to have a positive response to receiving that paper is one example. And then on the other end of the interaction, having that nurse who receives the paper, again, acknowledge that that front desk person is truly doing the work that they're meant to be doing, which is serving the patients who present to the office, and being able to demonstrate some words of appreciation or affirmation for what that person is going through as well. So as you're building the workflow, again, in that situation, it's a physical paper that's being handed off. In typical process improvement work, we may just have identified there's a piece of paper that has X, Y, and Z information on it. Front desk person gives it to the nurse in the back. However, that's where we called out a very specific set of circumstances that we wanted each person in that interaction to demonstrate every single time that interaction happens.
Great.
I think there's others as well. I think adding check-in to huddles every morning, just asking for problems and status of individuals every day. There's lots of little ways to build into structure.
Great. Now, Dr. Maples, I know you've worked with participants across the country in this work. Can you tell us a little bit about what the impact, we heard, the great impact this has had on the folks at Parkview, but what impact it's had on the folks that you've worked with and some of the feedback they've given you?
From at least from a qualitative standpoint, almost universally, teams will, individuals and teams will say this is one of the most impactful experiences they've had in their entire career, and some of those people are early in their career, others have worked 25, 30 plus years. So it's the way the work is done and how it engages people is really creates a sense of value, a sense of appreciation, and with that, a willingness to engage. We have seen other objective outcomes of patient satisfaction, employee engagement, turnover, all the way to actually safety metrics and outcome metrics be profoundly impacted. So the whole value of delivering care, the efficiency of delivering care, as well as one of the primary goals of helping individuals and teams reach that thriving and resiliency now that we have a way to truly measure it in a validated metric system. All of those things have been witnessed at the various organizations we've had the privilege to work with.
Great, and I think probably Dr. Clark, start with you on this one. I was actually going to ask a quite similar question. For those that may have been more reluctant to accept the process or to really get on board at first, what's helped them to gain buy-in? Has it been peer pressure, or how are you incenting those that maybe you haven't put through the program initially to now be ready to go through and participate?
So you definitely want to get to critical mass of people as it relates to peer pressure, or what I would just call normative healthy behaviors being demonstrated. Again, getting back to modeling makes a big difference. But additionally, it gets back to having foundational principles and the ranking of the priority of those principles to be able to ask questions in response to that as, is this in the patient's best interest? Is this in the team's best interest? Are we respecting every member of the team by including or not including them in this discussion right now? And so it's not by telling people, it's more by asking, demonstrating, and sharing the feedback that the rest of the team gives.
And this is Bill. I'd like to, just add a little bit to what Dave said. Everything was spot on. The way that the program is designed is to really leverage the self-discovery, and people that are engaging really can ask the question and answer it quite quickly at every step of the way. What's in it for me? And when they're able to do that, that on their own, not being told what's in it for them, but actually discover that, it really helps even the most reluctant learners, come along.
Absolutely.
I would also, add that the folks who participated in this work were some of them were somewhat reluctant as well going through the steps. But I think it's really important to call out the fact that it's so significant to go through the process that once folks got to the end of the process and could really appreciate how all of the steps come together and how you really look at improving your workflows, removing your hassles, having better human connections, and improving those relationships, those folks were so excited at the end of it that rather than thinking about it in the traditional negative peer pressure stance, other folks just really wanted to tap into that as well. So it's that excitement that carries on. And then another example that I have is, as Dr. Clark mentioned, one of the skills that's very easy for a team to grasp early on is the daily check-in. And that's a very dedicated question of, how are you doing today? Is there anything you need to leave behind so that you can really be engaged today and do your best work possible? So it's a little bit different than just the throwaway question of, hey, how are things going? And when you really do that with a team, that allows folks to, again, have that vulnerability and continue that team discussion. And an example is early on, when we first started doing that after the initial training, it was literally the very next day during huddle. And as soon as one person said, oh man, are you kidding? We're really going to do that? Then I was so proud of our supervisor, who is normally very conflict averse, but she was very comfortable saying, ouch, I don't know if you meant to say it that way, but that kind of hurt my feelings. Yeah, I actually really want to try this. And that person then, of course, apologized and really felt horrible. She was trying to be a little bit goofy, like be a little bit funny, and just really being transparent and saying, no, as a team, we're really going to talk about these things. Then it allowed everyone to understand right off the bat, day one, okay, no, we're really investing in what we're saying that we're investing in.
I think an interesting point is that from a neurobiology standpoint, to change your mind, you literally have to create new neurologic connections between nerves in your brain, and that takes time for those things to happen. And I think some of the tools that Dr. Maples referenced, exercises, sort of reinforce those things. And you can literally see people changing the way they're thinking about problems as you move through that process. And that's why I think the continued effort of it is important.
Absolutely. And so sort of follow up on that, to those who have participated, really, I know I've heard they certainly are value this program, but do they really agree that the outcomes provide them a good time value?
If that's a question for me, the answer is Yes, and I think that again, one of the big learning experiences that the complexity of processes and that how big the actual team is. It's not just you and your nurse. It's not just you and the patient. The delivery of care team is very broad, very deep, and you need to factor in all of those people in the decision making. And I think when people come to terms with that, again, that's one of those fundamental shifts that occur where now I need to go out and talk to people to make sure that that works well for me or not.
I would add to that when folks are really feeling frustrated with a career that they've devoted so much time to, if they can see light at the end of the tunnel to say, oh my gosh, I get it. I understand that this is a pretty significant problem in my day. I just didn't know how to fix it, but now I feel like I understand that there's a process to it. It's not just a simple fix, and I can actually participate in that solution, then folks definitely felt like it was worth their time. I also, again, want to reiterate what Dr. Clark had mentioned earlier, is that we blocked time in the midst of their day to be able to accomplish this work. And especially post-COVID, I completely understand that that's going to be a big financial ask for any group that undertakes this work, but it is so important, and that again demonstrates the commitment that we as an administrative team have to those folks who do the work every day with our patients.
Absolutely. All right, Jillienne, I have one more question for you, since it sounds like a lot of this, the operations of making all of this happen rested with you. You know, if you could go back now and say, what would you have done differently other than probably not try to do this right in the middle of COVID and all that change? Do you have some ideas of what you might have approached differently? And then I'll ask you, Dr. Clark, from your perspective, if there's something you would have done differently.
I think early on, I felt like I was communicating quite a bit what this program looked like and all of the steps, but until folks actually go through it, it's really hard to identify where they're at in the process. So I had thought through just maybe some better visuals or something that would allow the rest of the team to have a real-time understanding of where we were in the process. And that's a realistic thing I've reflected on. The other thing then, of course, that I would say is I just wish we would have started it earlier.
Dr. Clark?
Yeah, I would agree with all of that. I think that we had already been doing some of this work in a foundational way without the same sort of structure behind it. So yes, I would like to have got through sooner, but I also think that as it relates to the learning of it and the adapting of it and the embracing of it, you can't force that, and it doesn't happen with immediacy. And a lot of the post comments were from people who early on who had said, I think this is sort of corny and sort of silly, to at the end, you know, we need to do more of that. And additionally, as it relates to understanding the complexity of that, there were requests when people first arrived as to when do we have physician-only meetings? And my question was, why would you want such a thing? And I think after the people go through that process, that they understand what I mean by that. If the whole rest of the team has no voice, if they can't tell you 10 reasons why that doesn't work for them, you're just going to end up going down a rabbit hole. And the notion that we don't meet as a team and talk as a team, physician-only meetings just seem irrational at some point.
Absolutely. All right, I know we're getting close to the top of the hour. Let me ask Dr. Maples if you have any other closing comments, but I just want to thank you for a great presentation and sharing your great journey.
I want to just give thanks and gratitude to the Parkview team. They've been just awesome to really work with and to really watch their team reach that peak performance. And I just want to close again with gratitude to the American Hospital Association and to Vocera and to the Institute for Healthcare Excellence for really being supporters of the task force. None of this work would have been possible without that dedication, and I'm forever grateful for that. Thank you.
All right, well, thank you.
Grateful for all the help.
Thank you all for joining us. I just want to remind you that our next webinar, which will be about the stigma around opioid use disorder and how to address that, will take place on August 12th. Information will be coming in your email. But thank you so much to everyone who joined us and to our presenters again. As mentioned in the chat, the recording of this presentation will be up on our website later this week. Thank you and have a good day.
Thank you, ladies and gentlemen.